Today I will be discussing the treatment options for schizophrenia and how these treatments relate to the underlying pathophysiology of the disease itself. Schizophrenia is a chronic psychiatric disorder that affects approximately 1% of the population worldwide. It is characterized by positive symptoms, which include hallucinations, delusions, disorganized speech and behavior, paranoia, and agitation. Negative symptoms, including a flat affect, social withdrawal, decreased motivation, reduced speech, and cognitive symptoms, including poor attention, memory deficits, impaired executive functioning, and difficulty processing information. Although there is no cure for schizophrenia, treatment can significantly reduce symptoms, improve functioning, decrease the risk of relapse, and thus keep people in the community. Psychotic disorders are the only psychiatric disorder that permanently changes someone's baseline of functioning. It is important to note that each psychotic episode causes further brain damage and requires a longer period to return to their baseline post-diagnosis. Repeated relapses and extended periods without medication cause further deterioration and deviation from that baseline, and typically will require an even longer period to stabilize. It is not uncommon for patients to require long-term locked residential treatment for stabilization and community reintegration. Understanding the pathophysiology of schizophrenia helps us explain why different medications work and why adherence to treatment is so important. To understand the treatment, we first need to understand the disease itself. The exact cause is still unknown, but research suggests that it results from a combination of genetic, environmental, and neurodevelopmental factors that disrupt normal brain function. For males, the onset of symptoms typically starts in the transitional ages between 18 to 24, females mid to late 20s. The most widely accepted explanation is the dopamine hypothesis. This theory proposes that excessive dopamine activity within the mesolimbic pathways contributes to positive symptoms like hallucinations and delusions. At the same time, decreased dopamine activity in the mesocortical pathway is believed to contribute to negative symptoms and cognitive impairment. More recently, researchers have recognized that schizophrenia involves multiple neurotransmitter systems. In addition to dopamine, abnormalities involving serotonin, which contributes to mood, cognition, and psychosis, glutamate, NMDA receptor hypofunction may cause psychosis, and acetylcholine, where muscarinic receptor dysfunction increases psychotic symptoms. These neurotransmitters interact with one another, helping explain why schizophrenia is such a complex disease and why different medications target different receptors. Historically, the first medications developed to treat schizophrenia were the typical or first-generation antipsychotics. Examples include Haldol, Thorazine, and Fluphenazine. These medications primarily work on blocking dopamine D2 receptors throughout the brain. Since excessive dopamine activity in the mesolimbic pathway contributes to psychosis, blocking dopamine reduces hallucinations, delusions, and agitation. However, dopamine also plays important roles in several other brain pathways. Because these medications block dopamine indiscriminately, they often produce significant side effects. When dopamine is blocked in the neurostriatal pathway, patients may develop extrapyramidal symptoms, or EPS, which include Parkinsonism, muscle rigidity, dystonia, or akathisia, which must be treated with a separate medication, including cogentin. Long-term dopamine blockades can also lead to tardive dyskinesia, which causes involuntary repetitive movements that may become permanent. Blocking dopamine within other specific pathways can also increase prolactin levels, leading to sexual dysfunction, menstrual irregularities, and lactation of breasts. Although typical antipsychotics are very effective for positive symptoms, they have less of an effect on negative symptoms and overall cognitive deficits. The development of atypical or second-generation antipsychotics represented an important advancement in schizophrenia treatment. Examples of these include risperidone, Zyprexa, Seroquel, Abilify, and clozapine. Like typical antipsychotics, these medications block dopamine receptors, but they also block serotonin 5-HT2A receptors. The additional serotonin blockade allows dopamine release in certain brain regions, particularly the neostriatal pathway. As a result, atypical antipsychotics generally produce fewer EPS effects than first-generation antipsychotics. Some atypical medications also provide modest improvement in negative symptoms and mood symptoms because they better balance multiple neurotransmitter systems. However, this benefit comes with different risks. Many atypical antipsychotics can cause significant weight gain, insulin resistance, diabetes, and metabolic syndrome. This is imperative when weighing pros and cons of medications, as patients who lack insight into their illness often do not believe that they are indicated and will not take them. If left untreated, there are dire consequences. Clozapine deserves special mention because it is considered the most effective medication for treatment-resistant schizophrenia. However, it can cause a significant drop in white blood cells and requires patients to receive regular blood monitoring throughout treatment. And this medication can cause seizures or death if not taken consistently. There is no long-acting injectable available in this formulation. Another important treatment advancement involves long-acting injectables, commonly called LAIs. Not all antipsychotics have injectable formulations, but some that do are Risperdal Consta, Invega Sustenna, Aristada, and Haldol Dec. Unlike oral medications that must be taken every day, LAIs are administered every 2, 3, 4 weeks, every 3 months, or even every 6 months, depending on the formulation. However, it is important to note that in practice, it is common for the longer formulations, those over 4 weeks, to eventually lose efficacy. Patients can decompensate, and we as providers have limited options for treatment due to the amount of medication still being released in the system. Depending on the patient, we typically recommend formulations that are administered every 3 to 4 weeks. This is especially important because medication adherence remains the leading cause of relapse in schizophrenia in the context of poor insight and baseline paranoia. When oral doses are missed, the dopamine receptor blockade rapidly decreases. This allows abnormal dopamine signaling to return, increasing the risk of psychotic decompensation and rehospitalization. LAIs maintain stable therapeutic drug concentrations and consistent dopamine receptor occupancy. This prevents the fluctuations that often occur with daily oral medications. Numerous studies have demonstrated that LAIs improve medication adherence, reduce relapse rates, decrease hospitalizations, and improve long-term functional outcomes. The newest advancement in schizophrenia treatment is Cobenfy, which was approved by the FDA in 2024. Unlike every antipsychotic that came before it, Cobenfy does not primarily work by blocking dopamine receptors. It is formulated with 2 medications, xanomeline and trospium. Xanomeline stimulates the muscarinic MM1 and M4 acetylcholine receptors within the brain. Rather than directly blocking dopamine, activation of these receptors indirectly regulates dopamine activity within brain circuits directly involved in psychosis. Trospium was added because it blocks muscarinic receptors outside of the brain. This reduces unwanted cholinergic side effects such as nausea, vomiting, excessive sweating, and diarrhea without interfering with the medication's effect in the central nervous system. From a pathophysiology perspective, Cobenfy is significant because it demonstrates that schizophrenia is not solely a dopamine disorder. Instead, abnormalities involving the acetylcholine also contribute to psychosis. Clinical trials have shown that Cobenfy improves positive symptoms while producing minimal EPS symptoms and less weight gain than many traditional antipsychotics. In conclusion, schizophrenia is a complex neuropsychiatric disorder involving abnormalities in several neurotransmitter systems, particularly dopamine, serotonin, glutamate, and acetylcholine. The treatments we use today are designed to correct those neurotransmitter imbalances. Typical antipsychotics primarily block dopamine receptors, while atypical typically target both dopamine and serotonin. Cobenfy introduces an entirely new mechanism by targeting the cholinergic system, expanding our understanding of schizophrenia beyond the dopamine hypothesis. LAIs further improve outcomes by increasing medication adherence and maintaining consistent neurotransmitter regulation. As our understanding of schizophrenia's pathophysiology continues to evolve, treatment strategies are becoming more targeted, leading to improved system control, fewer adverse effects, and better quality of life for individuals living with this chronic illness. One of the biggest shifts in schizophrenia treatment is that we are moving beyond the dopamine hypothesis. While dopamine dysregulation remains central to the disease, newer therapies demonstrate that multiple neurotransmitter systems play important roles in the pathophysiology of schizophrenia. This evolving understanding is leading to treatments that are more targeted and potentially better tolerated.